Okay, well, welcome everyone to this evening's webinar. For those of you joining us live, thank you for taking the time out of your evening, and for those who will watch on replay, thanks for taking the time then as well. I'm just going to start with a little bit of background introduction before we move to me introducing Daniel, who's talking for us this evening, and leave Daniel to talk about canine blindness. So just before we get started, just to give you a little bit of background on VET.CT. VET.CT is well known for its radiology service and has been providing that for many years. And we have over 200 specialists through the radiology service and the specialist advice service, which is the section that Daniel and I work in. And just to give you a little bit of information about what we offer with the specialist advice, we essentially provide written advice within 12 to 24 hours across 13 specialties. So you get a real multidisciplinary experience on this. And we also provide the opportunity for live interactions in medicine, neurology, oncology, and orthopedics at the moment. We're often faster than that 12 to 24 hours, but that's the sort of turnaround time we say. Some of the advantages of our service is, say you created a medicine case that came to me, then I thought, well, actually, it's got a bit of an ocular problem. I'd like to get ophthalmology's input. We actually organise those extra inputs behind the scenes for you at no additional cost. So the client's not having to sort of think about whether they want that multidisciplinary advice. It's just coming as part of it. And we also offer unlimited follow-up. So if you get some bloods or you get some follow-ups on the eyes, you can come back to us with those additional information, and we'll give you that advice as part of the original case. Some of the things that we find that clients like is that it means they're not having to travel with their pet, they're staying with you, their bonded clinician, and so they've got the confidence to know that their pet's getting the best supported care. So we like to think that we're sort of collaborating with you on that. When you get our written advice, you'll get clear, simple advice to follow, answering the questions that you've specifically asked. So if you want to know more about the service, there's a QR code on that slide, or there's a QR code here, or you can drop me an email. My name's Kate Murphy, and I'm the head of Teleconsulting Clinical Services. So I'm also an internal medicine specialist, and I'm working to develop the service, but also on the service, providing advice on a daily basis to our clients around the world. A little bit of housekeeping for you tonight. This is being recorded, so we will make the link available to you within the next few days if you are watching on catch up or you want to watch some things back. Chat is disabled in this webinar function, so you're not able to send us chat messages, but what you can do is if you've got questions, you can pop them into the Q&A box, which is at the bottom of the Zoom screen. You can click on the Q&A, enter questions, and when we get to the end, I will ask those to Danny, because we don't have the ability for you to come live and ask them yourselves. So without further ado, I will introduce you to Daniel Costa. Daniel is one of our excellent ophthalmologists at VET.CT. He spent a lot of your formative career, I think, Danny, in Barcelona, and then you've also worked in Valencia, in the UK, and now in Hong Kong. But tonight, Danny's joining us from Valencia, so he's got a lovely sun behind him to take us in, and you're going to talk to us about canine blindness, the causes and treatment. So I hand over to you, Danny.
Okay, thank you, Kate, for the introduction. So I'm going to start with the talk today. I'm going to talk about canine blindness, and mainly I'm going to talk about the acute blindness. We're going to give you some tips of all the kind of blindness, but mainly what I want you to take home from this talk is to know what to do when a dog arrives to your consult and the owner say, I think it's completely blind, or it's lost the vision, or partly lost the vision. So this is what I'm going to try to help you with, and to try to give you some advice on how to do the test, what tests you need to do, and what can be the causes and the possible treatments for these problems. So to start with as for any consult, and we need to ask some questions to the owners to know a bit more about the case. Sometimes it's difficult to know and to take this information from the owner because they don't really know, they don't really show how it developed. But it's important to know if the blindness is acute, if it's been in the last few days, or it's been the dog has been blind for a few days already or weeks, This is important for the treatment sometimes, because if we have an acute glaucoma, for example, we can do an acute treatment and reduce the pressure of the eye quick and maybe have some vision back if it happened in the last 2-3 days. But it's been for a few weeks, probably it's not worthly to do emergency treatment, because it's been there for too long and probably the eye is completely blind. So yeah, for how long, and if they think it's one eye or is both eyes, if it's bumping into things from one side, from both sides, and the other important thing is if they think the dog is completely blind, or they notice a reduction in the vision, because this can also guide us to the diagnosis. Another thing important, especially for the retinal problems, is to try to figure out if the dog is is blind during all the day, or is blind more, or especially at night or during the day, because this can guide us to some retinal problems. And most of the retinal problems, I will tell you later, start with the atrophy of the rods that are the cells responsible for the night vision. So if the owner says that at night when they try to go out, the dog don't want to go out, or they only follow the lights in the street or things like that, or until they switch on the light of the corridor, they don't move, things like that can give us some clues of what is going on where we can look for the problem. Another thing that is important is to know about the history of the diseases of these animals. So if there is any systemic problem or any clinical sign that can guide us to any systemic problem, that PUPD, gain or loss of weight, dogs with cataracts, for example, as we know, they can develop cataracts very easily. So around 80% of the dogs with diabetes develop cataracts in the year and a half after the diabetes starts. So this is another thing that is important to know. If there is any recent medication, because as I will tell you, some medication can be toxic for the eye and give a blindness, or some vaccine reactions or allergies also can lead to a blindness or partial blindness. And yeah, apart from medication, any toxic substances can atrophy the retina, degenerate the retina, and lead to a blindness. So after we do all these questions, we need to perform a complete physical exam, as we do in all the consults, and focus in the ophthalmological exam. It's important to do a complete exam, try to do as much as we can or as much as we have in our consult, because as much information we have, the better to know the diagnosis, to arrive to a diagnosis. And we always advise you to do the exam from outside to the inside, looking at all the parts of the eye, and don't miss any part, because it's very easy to go directly to what you think is the source of the problem. For example, when they have an ulcer, we go directly to the ulcer, but we miss the eyelids and we miss the facial conformation, for example, and maybe the problem is something that is in the eyelids and is producing the ulcer. So we are missing this. So even if there is something that is very clear and you want to focus on it, step back and try to look at everything before. What is gonna tell us more about the blindness is the neuro-ophthalmology, and especially what we use in ophthalmology, in veterinary ophthalmology, is the Menas response and the tarsal reflex and the pupillary reflexes. This is gonna tell us about the vision and light reaction of the eye. About the so when we say a dog is blind, it's when has a negative menace response. If you are not sure about the menace, you can do other tests like the cotton ball test, that is throwing something that is not going to make any noise when it arrives to the table in the side of the dog, and see if the dog is following this goal, so this swap or this cotton ball. This is why it's called cotton ball test. You can do a maze test as well, putting some obstacles in the console and see how the dog navigates. So if you are not sure if the menace is negative or not, you can do this test to know if the dog is really blind or not. So for this lecture, this webinar, I'm gonna follow this diagram. This diagram starts with the negative menace, so no vision, no reaction to the vision, and we are gonna go through every part of this diagram. So after we do the menace response and we see that the menace response is negative, we know that the dog is blind. After that, we do the rest of the exam, ophthalmic exam, and we are going to start with the central blindness. That is when we have a negative menace response. We have the rest of the exam, ophthalmic exam, normal. And when we have the rest of the exam normal, we don't see any cause inside the eye that explain us this loss of vision. So when we have a normal ophthalmic exam with a negative menace response, then we need to do an ERG, an electroretinography. The electroretinography is going to divide us or make us decide if the blindness is coming from the brain or the optic nerve or central, or if it's coming from the retina and we still cannot see anything in our normal ophthalmic exam. So if the ERG is normal, so we have a curve in this ERG, then means that the eye works completely fine, that there is no problem in the eye, and all the structures, as we saw in the ophthalmic exam, are normal. So the problem is in the brain or optic nerve, so it's behind the retina. I'm not gonna go very in deep in this problem, because then we see this, we send this case to neurology, and as a general practitioner, you cannot do a lot more. And then, or if you have a MRI, then the next step is to perform an MRI. About the central blindness, and I'm only going to show you this slide to guide you a little bit and help you to guide the owner to tell what can be happen behind the eye. So we need to do an MRI or a CT. The MRI is better for these kind of problems. And what we can find in the MRI or CT is retrobulbar optic neuritis. That means that the optic nerve is inflamed, but we don't see it inside the eye. So the inflammation doesn't arrive to the optic nerve head. But when we do the MRI, we can see it, and this is usually due to meningoencephalitis of unknown origin. Then another thing we can have to have a central blindness is an optic chiasm neoplasia, or other alterations like brain neoplasia, hemorrhage, or any encephalopathy or meningoencephalitis of other origin. In this MRI I show you, there is a mass in the brain, and is the cause of the blindness. Now we go to the things where in ophthalmology we treat, starting with the retinal blindness. In these situations, we have a negative menace response with the rest of the ophthalmic exam can be normal or abnormal. If we see a normal ophthalmic exam with a flat electroretinography, means that the problem is in the retina. But usually in these acute retinal disorders, you cannot see anything in your normal exam, and you just see a normal retina, but the retina is not working because the electroretinography show us that the retina is not working. The retina is the part of the eye more difficult to assess. All these pictures are from normal fundus. Some of the optic nerves with more myelin, some with less myelin, some with more pigment in the notopetal area. We have some albinotic or subalbinotic eyes. So it's one of the parts of the eye more difficult to assess. So I recommend you to have a look to the back of the eye in all the patients that arrive to the consult. If you have a little time with the direct ophthalmoscope, have a look to all the eyes that comes for a vaccine, for anything that comes to your consult, because then you are going to be more familiar with the normal variations. And if there is something that is not normal, you will pick this. Maybe you are not sure what is happening, but you can think, oh, I never seen this before. So there may be something there that is not normal. So this is how you can train yourself and know if something is going on. So all these fundus are normal, and in these situations where we have a normal fundus with a flat ERG, we can have one of these three causes of this problem. The SARS is the most common in dogs. That is a sudden acquired retinal degeneration syndrome. The cancer-associated retinopathy, some books or some papers, you will see this inside the SARS. In some others, they divide it. So, well, at the end, the clinical signs are the same. And an intoxication can lead to complete blindness with a flat ERG and no fundus abnormalities, as you can see in the picture. Going to the SARS, so the sudden acquired retinal degeneration, is a disease, a syndrome that we see only in dogs. It's not described in any other species. When we first see the dog, we can have some pupillary reflexes, but we have a negative menos response and a negative dazzle. Some dogs has a PUPD and polyphagia. Some others don't. So it's a big syndrome that we put all together because it's very difficult for us still to differentiate, and there's a lot of research going on this syndrome to try to divide it in the different causes. But for now, everything is in the same sack because the clinical signs are the same. So what we have dogs with PUPD, dogs without PUPD, and dogs that we found the cause, dogs that we don't find the cause of it, but still call it SARS. What we know is that there is an acute death by apoptosis of the retinal cells, and this leads to a permanent blindness and irreversible blindness. So there is no treatment for that, no treatment at all, and we have a completely flat electroretinography. If we see these dogs, this fundus is maybe 6 months, a year after everything happened. You can see retinal atrophy, so hyperreflectivity of the tapetum, attenuation of the retinal vessels, but at the beginning, the fundus will be completely normal. In most of the cases, we don't know the causes, but we know that around 5-10% of the cases, we have an underlying Cushing disease. So the cortisol goes to the eye and kills the cells. There are papers describing high sexual hormones. So a high estradiol, progesterone can produce as well death, an acute death of the retinal cells, and we assume and we think that most of the cases are immune mediated, and we cannot do anything for that. But I always recommend the owner. I always tell the owner that there's a little chance to find the cause. But if there is a Cushing or a high sexual hormones, probably due to a neoplasia, a tumor somewhere, is worthy to do test, to do blood test, and to check for these diseases and rule out these diseases, because we need to treat them if they are present. And if they are not present, we don't know the cause, and we are not gonna have any resolution of the problem. The dog will stay blind, but there will be no other complication. Usually there are no other complications. If you want to know more about this problem, you have this paper that is very good, already a bit old, but from this paper they start studying and doing more research about the SARS, and this is a review with all what we know about this disease. And then you have here as well the paper that explain about the sex hormones, if you want to have a look. Another describe disease in dogs that produce this sudden retinal blindness. Retinal death is the cancer-associated retinopathy. It's an immune-mediated disease due to a paraneoplastic syndrome. There is more information in humans. In humans also happens, but we don't have a lot of information in veterinary medicine. Only a few case reports describing mainly melanomas, and that we know is that the clinical signs are similar to the SARS. And sometimes we see this blindness before we know there is a tumor. So another thing to consider is, well, of course, do a complete physical exam, and if the dog is getting old or there are other concerns, then perform some imaging to rule out any tumor in the body. As I said, some papers and some books put this CAR inside this cancer-associated retinopathy inside the SARS. Some put it apart. So, well, it doesn't matter. At the end, we need to know what is going on and what are the differences. And then in dogs, most important intoxication that produce this retinal blindness without any other sign is the hyperverting intoxication, and is mainly in dogs with the MDR1 gene mutation. There is some descriptions in cats and horses, but are very few case reports. And we have a flat ERG with normal retina. Sometimes we can see something in the retina, but most of the times we don't see anything. And in some cases, if the doses are low, we can have a recovery or partial recovery of the vision, but in most cases, the dogs remain completely blind. And once the retina is dead, there is nothing to do. The retina don't regenerate. Is cells that once they die, they don't regenerate. So if we have an atrophy of the retinal cells, we don't have vision, and the vision is not going to recover. So until here, the retinal blindness. So we did the first part when the ophthalmic exam is normal. We have a negative menace response and a normal ophthalmic exam. And we already went through the central blindness very quickly, because this is something that the neurologists deal with. And when we have a flat ERG, we need to try to figure out what is going on in the retina, why the retina is not working, and why the retina is dead. Now we are going to go to the second part, that we have a few more diseases that for the ophthalmologists. And it's when we have a negative menace response and an abnormal ophthalmic exam. Here I divide it in two parts. The first part is when we see all through the eye, so we can see from the front to the back of the eye. We usually have a diagnosis with our ophthalmic exam. and I'm going to go through the possible diagnosis that we have in these cases, and the other possibilities that we try to look inside the eye and we don't see anything inside the eye. So then we need extra tests. We need to perform an ocular ultrasound or sometimes an ERG. And with that, usually we arrive to our diagnosis. So we are going to start with the ocular blindness when we can see something inside the eye. And in these cases, we can have retinal detachment, retinal hemorrhages that can produce complete blindness or partial blindness. Diffuse chororetinitis, again, can produce complete blindness or partial blindness. Optic neuritis, that we can see it. So because in the first part, as I told you, sometimes we can have an optic neuritis behind the eye and we don't see anything in the optic nerve head. But in some cases, we already see it in the optic nerve head. So we already have the diagnosis before do the MRI. In these cases, usually it's completely blind. Some cases we have some mild vision. And the other thing I put in this section is the PRA, the progressive retinal atrophy, and the senile retinal degeneration. That the clinical signs are the same, but the onset and the way it works a bit different. So I'm going to explain the differences between both things. If we start with the retinal detachment, we can have two types of retinal detachment. We have the bullous retinal detachment that is in your picture on the top right. And we can have regmatogenous or complete retinal detachment that is in your bottom image in the right, when you see all the retina completely fold over the optic nerve. So the optic nerve is under this fold, that is the retina. The diagnosis and the prognosis are different. This is why we divide it. And when we have a bullous retinal detachment, there is an underlying cause that usually is infectious or a kidney failure due to hypertension. So we need to treat the cause. And if we treat the cause quick, we can have some vision back. So we need to start as soon as possible with our treatment, our diagnostic test, and our treatments. And especially if it's an old dog with this kind of retinal detachment, you should check for the blood pressure. And if the blood pressure is high, start with therapy for this high blood pressure, usually with amlodipine. If you don't have a high blood pressure, and you need to do tests and rule out all the infectious diseases, and start the treatment of the infectious diseases, if any. For the retina itself, we don't have a lot to do, but we can help the exudation to remove and reduce the exudation with systemic steroids. But if the kidney failure is too bad, then we cannot give it. So depends on the diagnosis, depends on the cause. So you need to know, assess, or ask our internal medicine specialist if it's possible to give systemic steroids. Never use diuretics. I've seen it sometimes, and it's not indicated in these cases because it can worsen the condition and bring more water to the back of the eye instead of reducing it. So the treatment for that is look for the cause, treat the cause, and if possible, we can give some anti-inflammatories. If we are lucky and this has been there for not a long time, the retina will go back to normal and the vision can recover partially. If we have a regmatogenous retinal detachment, we can have it after a cataract surgery, or some dogs have a primary one. So we can have a whole or a completely detachment of the retina. What most of us can do for this, if we see it when starting, we can do a retinopexy, that is a barrier with a laser. In some cases, they start doing the vitreoretinal surgery, that is to replace and put back the retina to its place when it's completely when it's complete the retinal detachment. The only thing we can suggest to the owner is to do a vitreoretinal surgery, and there are a few places in the UK, and it's starting to be more common over the world to do this surgery. And the weakest point of this surgery is that sometimes we arrive too late because the owner don't realize soon. The diagnosis is late, and at the end, when the doc arrives to the place that they can do the surgery, it's too late, and the retina is not working anymore. And as I said, once the retina is dead, there's no way to make it work again. So this is what we can do with a regmatogenous retinal detachment. And so these are the two kinds of retinal detachments. The causes I already went a bit through it. It can be infectious, vascular, and systemic hypertension, but we can have also a paraneoplastic syndrome. It's very unlikely to be immune-mediated or traumatic. If we went through the differential diagnosis, the most common infectious diseases is in most of the world is temper. In the Mediterranean area, leishmania can produce this exudative retinal detachment. A coagulopathy, thrombocytopenia, anemia, or hyperviscosity can produce also exudate in the back of the eye, and although it's not as common as the systemic hypertension, we can also have a retinal detachment due to one of these causes, and some paraneoplastic syndromes or infiltration of the tumor in the back of the eye. The lymphoma can infiltrate the retina, and the mammary or pulmonary carcinoma usually is a paraneoplastic syndrome. But these are both of these are the two systemic tumors that affect more the eye in general, and one of the targets is the retina. Immune-mediated and traumatic, as I said, is very unusual. You need to rule out every other problem, and you need a very big trauma to produce a retinal detachment. So it's very unlikely. Going to the next possibility of blindness when we can see all the way through the eye. We can find big retinal hemorrhages that can be at the same time, can appear at the same time as the retinal detachment or in their own. Sometimes the systemic hypertension produces bleedings in the back of the eye and don't produce any retinal detachment. Sometimes we have both things. We have the bullous retinal detachment and we have the hemorrhages. Any coagulation disorder, hyperviscosity, anemia can produce these ruptures of the retinal vessels. The retinal vessels are very thin and are very sensitive to the changes in the pressure. This is why the back of the eye is one of the places of the body where we have bleedings sooner when we have a systemic hypertension. Infectious diseases. The infectious diseases that can cause coagulopathies, any kind of ehrlichiosis can produce bleeding in the back of the eye, and if we see a bleeding in the back of the eye, this is the cause of the blindness. If it's not very big the bleeding, or there is not a lot of blood, the blood will reabsorb slowly, and the vision can be recovered. If the blood is filling all the back of the eye, the prognosis for the vision is bad because the blood is going to kill the cells of the retina, and the eye will stop working and will stop having vision, like permanently. Another possibility to have a blindness when we can see the retina is chorioretinitis. The chorioretinitis is an inflammation, as the word says, of the choroid and the retina. The choroid and the retina are two layers that are very close together, and anything that affects one layer affects the other. So this is why we call it chorioretinitis, and very unusual, and nearly never you will see choroiditis or retinitis so apart. So we always put these words together. The most common cause of that are infectious diseases. So do all the tests of the infectious diseases that you have in your area, or any septicemia, any inflammation in the body that can have infection of the blood and can arise to the eye, can produce this chorioretinitis. In the pictures, you see these blurry areas that are chorioretinitis area. Usually are more light, but if it's in the pigmented area, can looks more white, and it looks like a cotton ball going out of the retina, so something that is protruding from the retina and looks very blurry, and all this area around looks very, very blurry. So this is how you can think this is a chorioretinitis. If it's active, you can see it very blurry. If it's passive or chronic, means that the infectious disease happened, and now it's under control, and you can see areas of hyperreflectivity in the back of the eye. But yeah, when you see acute blindness, or when the owner came saying that the dog cannot see, usually you are in an active stage. Small chronic chorioretinitis, usually the owner don't realize, and the dog don't have any visual problem. The possible infectious diseases that can cause this chorioretinitis are the Leishmania, again, in the Mediterranean area, Toxoplasma, Ehrlichia, and distemper. Distemper is the only one that we sometimes say that is a retinitis, but again, it's all together. So, but we know that distemper affects first the retina and then goes to the cornea. Anyway. Some immune-mediated diseases and neoplasia can produce this as well, but is the less likely. So before think that can be immune-mediated or can be a neoplasia, we need to rule out all the infectious diseases and be sure there is no other focus of infection in the body. And so yeah, do the infectious diseases. If everything is negative, imaging, chest X-rays, abdominal ultrasound, plus minus CT, and with that we will see if there is any focus of septicemia, or if there is any neoplasia in the body that can start producing this inflammation of the retina. Okay. So yeah, so I already explained you about this, talk about this. Usually we have a systemic problem, so look for it. Physical exam, CV, biochemistry, a test for the infectious diseases, and imaging. Treatment, we don't have any specific treatment for this problem. Again, if there is no problem in the systemic blood test, that contraindicate the systemic steroids. This is an inflammation, so it's gonna get better with systemic steroids in anti-inflammatory dose. But well, as we all know, some diseases will contraindicate the systemic steroids. So first, we need to do all the tests, and if we can, if we start with systemic steroids, we will have more chances of recovery of the vision. The next one is this image. If you look a bit at this image, you will see something strange around the optic nerve head. It's quite pinky, and the blood vessels are curved when they arrive to it. So in the real life, you will see this optic nerve protruding to you. And when it's bigger, more fluffy, pinky, and protruding is optic neuritis. You have here another picture of an optic neuritis. Again, in a picture, you can follow the vessels and see that there is a curve when arrived to the optic nerve. Here is very obvious. If you've seen it in real life, you see it if you have a look to the back of the eye with a direct ophthalmoscope. you will see the optic nerve blurry if you focus the retina, and that means that the optic nerve is protruding. And if you move back or you move the diopters of the direct ophthalmoscope, you will focus to the optic nerve. The differentials are mainly meningoencephalitis of unknown origin, so we need to send it to a neurologist, and they probably will do an MRI to see what areas are affected. You can also see this with a high intracranial pressure, with intracranial neoplasia and other conditions, and some infectious diseases can produce this optic neuritis as well. So yeah, again, this is a condition that you can see in the back of the eye. This is the cause of the blindness, but after that, we need to send it to a neurologist to do the further investigation and to know the treatment for this specific case. And well, depends. I'm not gonna go in deep on this. Depends on the condition. So if it's a GME or MUO, they will give systemic steroids and cytarabine. But if it's a neoplasia or something else, depending on the case, the treatment will be different. The last part of this is the PRA, or that is the progressive retinal atrophy or the senile retinal degeneration. They have the same clinical signs, vascular attenuation, so the blood vessels are thinner, there is a hyperreflectivity of the tapetum, and the blindness starts at night. There is a progressive retinal dye and degeneration and thinning. This is why we see it hyperreflective, and we have no treatment. The difference between both is that the PRA is hereditary, it has a great predisposition, and it starts when they have 4 or 5 years old. So they start having problems of vision with 4 or 5 years old. They will probably be completely blind with 9, 10 years. If they start having loss of vision at night, especially with 8, 9 years old, is probably age-related. It's a degeneration, and usually you can tell the owners that the dog will always see something, probably less and less, but they usually don't have a complete blindness. So these are the main difference. In any of the cases, we have any treatment that is effective or is described to be effective. Now we are going to go to the last part. Is when we have a negative Menes response with the rest of the exam abnormal, but we don't see anything inside the eye. Then we usually need other tests to arrive to the diagnosis. So it's when we have an acute glaucoma, and exudative anterior uveitis, very exudative, like in this picture with IFEMA and lipemia. When we have a cataracts, or we have an anterior lens luxation, like in this picture in the back. Acute glaucoma, we don't see because it's very blurry, it's very edematous, and we don't see inside the eye. And it's when we describe the glaucoma when we have an IOP more than 25 millimeters of mercury, and we can have primary or secondary glaucoma. This is a whole lecture, so this is a whole hour or two or a day of to explain all in detail, but I'm gonna give you some clues. So what we see in any kind of glaucoma is blindness, conjunctival or scleral hyperemia, corneal edema, and mydriasis that is not responsive. If we have a secondary glaucoma, that can be due to uveitis, luxation, synechias, we need to give the treatment for that. And if we have a primary glaucoma, that is an acute glaucoma, as I told you at the beginning. If we have an acute glaucoma, means that the dog has been blind for 2-3 days, no more. If it's been blind for more than 2-3 days, then it's too late. But if it's been blind for around 3 days or less, we can try this emergency treatment with drops first, wait 5 minutes and put on the other kind of drops. And if in 30 minutes, usually sometimes the pressure is already normal, then we need to follow the medical treatment. If so, stop if it's less than 25. If it's still more than 25, then we give the mannitol IV, 1 gram per kilo in 20 minutes, and usually this brings the IOP back to normal. After that, we need to continue with medication, and usually we hospitalize these dogs to make sure the IOP is under control. After it's controlled, we use these two kind of drops that are the ones that are described to be more useful in dogs, but we usually have a bad prognosis for these cases, and the dogs with glaucoma usually are blind in a few years after the diagnosis, and sometimes we can perform some surgeries that can prolong the vision but never cure the treatment. We always, never cure the condition. We will always have a complete blindness at the end after a few years. We have an exudative anterior uveitis, like in this case, we don't see anything inside the eye. We can do an ocular ultrasound to see if the back of the eye is affected as well, or it's only the front of the eye. If it's the back of the eye affected as well, the prognosis for the vision is bad. If it's only the front of the eye and we reduce quickly the inflammation, we can have vision recover. Infectious diseases can produce an anterior uveitis or systemic neoplasias, lymphoma or carcinomas are the most common. Metabolic diseases like diabetes or hyperlipidemia can produce as well this lipemic aqueous humor, and you see in the picture, and some blood as well. Coagulopathies, thrombocytopenias, or trauma can produce the exudative anterior uveitis, and if it's very severe, we can have vision loss. We usually recommend to do a diagnostic protocol in these cases, especially if it's very severe. Sometimes it is mild or it's only one eye. We give treatment and see. But in most of the times, there is something systemic that is producing this uveitis. So you need to tell the owner since the beginning that probably we will need more tests to find the cause, and the treatment that is we can give topical treatment, we can give medical treatment, but if we don't find the systemic cause, the medical treatment is not going to resolve the problem. Maybe it make it better, but it's not going to be cured if we don't treat the systemic cause. Sometimes we don't find the cause in 40-50% of the cases, and with treatment we recover it, but you always need to recommend the owner to do the systemic workup. For the uveitis, we need to use steroids if we don't have ulcers, topical steroids, and mediatic to move the pupil, because if we don't move the pupil, we will have synechias and probably a secondary glaucoma. If it's very severe, like in this case, and we can give oral NSAIDs or steroids, sometimes it's necessary to control completely the uveitis. The bilateral cataracts or a cataract can produce blindness, unilateral or bilateral. If we usually it's progressive, but sometimes the owners don't realize until it's completely blind, and sometimes they think and they come saying that the dog was visual yesterday and today is completely blind, which is not possible because this has been there for a long time, but probably the dog has some difficulties in the vision, but they were coping well, and the owner just realized that the eye is blind and has the cataracts when this is complete. The only option for the cataracts is the cataract surgery, the phacoemulsification. We don't have any other treatment, medical or surgical, to remove the cataracts or to control the cataracts. There are some drops that say that can reduce or control it or make it progress slowly. There is nothing confirmed, and the phacoemulsification has a high success rate in dogs. If we have a diabetic patient with cataracts, we need to do a cataract as soon as possible because diabetic cataracts is a cataract produced because there is water going inside the back of the lens, and this capsule, this bag, can rupture very easily and can produce a severe uveitis and lose the eye can be lost if we don't do a cataract surgery soon. We do 3 pre-tests before the cataract surgery, gonioscopy to reduce the possibilities of glaucoma after the surgery, an ocular ultrasound to make sure in the back of the eye there is nothing else because we don't see in the back of the eye. So the reason of the blindness can be the cataract, but can also be a retinal detachment, and this retinal detachment can produce a cataract secondary to this detachment. So we need always to do an ocular ultrasound to make sure there is nothing in the back of the eye. And the ERG, this is a normal ERG with a normal curve of the eye with a normal response. So we need to make sure everything works before we go to surgery to make sure we will have a vision recover. The phacoemulsification technique is the same we use in humans. We do a very small incision and we remove completely the lens material, so there is no recurrence of the cataract itself. We can have some opacification and some other things, but never recurrence. This is something that a lot of owners ask me. We usually put IOL, an intraocular lens implant, so the vision after the surgery is the same as before the cataract, and we need to suture the incision with absorbable sutures, so they will reabsorb alone in around a month. We can have some complications of this surgery, but they are not very common. The most common is the glaucoma and the excessive uveitis, but we can also have infections, rupture of the suture, especially if the dog is moving a lot, and sometimes retinal detachment. If we don't do a cataract surgery and we keep the lens because the dog is very old or because the owner cannot pay it or whatever the reason, we need to be very cautious and do regular rechecks to these eyes to make sure there is no uveitis, and if there is uveitis, give treatment for that to don't have secondary glaucoma or other problems, and check for lens luxation regularly because the cataract is heavier than the actual lens, than the normal lens, and the lens can luxate. That is the next and last part of the lecture, that is the lens luxation. When we have a lens luxation, an anterior lens luxation, we can have blindness for 2 reasons. One can be the lens itself that is obscuring the vision, or because the lens sits in the drainage of the eye and can produce a high intraocular pressure. Can be primary, can be in the genes. Sometimes they have genes, hereditary predisposition. Some breeds have hereditary predisposition, or can be secondary to the cataract. As I said before, the cataract is heavier than the normal lens and can luxate. If we can have a high intraocular pressure, and if we have a high intraocular pressure, the recommendation is to remove this lens, do an intracapsular lens extraction as soon as possible, because if we don't do that, the pressure will keep being high, and there is no medication or anything that can reduce this pressure, and the retina will suffer, and the retina will die, and the eye will be permanently blind. If we remove the lens, the pressure will go back to normal, and we have a high chance of have a vision back and maintain the vision. If the surgery is not possible because the dog is too old, we cannot have an anesthesia, wherever, we can do this technique that is described in this paper, that is sedating or anesthetizing the dog, trying to push the lens to the back of the eye, but this this procedure has complications. Sometimes it's not possible. You cannot pull it to the back. You have the lens moving inside the eye with can go to the front again and will produce a lot of inflammation and can produce retinal detachment and glaucoma. But if there is no other possibility and the eye is painful, then it's something you can consider. So this is all my talk, all was the things I had prepared for you. So I don't know if there is any questions.
Great, thanks for that, Danny. That was a fantastic talk covering so much that I'm trying to make sure I remember it all. If anyone has any questions, please feel free to pop those into the Q&A. I've got a couple to ask you at the moment, Danny. So you mentioned glaucoma and obviously that it can be primary or secondary, and that if it's a secondary, we should try and treat the underlying cause. And you talked about sort of the emergency treatment for the primary, but would you use the emergency treatment in a patient with secondary glaucoma as well?
If it's an acute glaucoma and the pressure is being high for the last 2, 3 days and it's a secondary glaucoma, you need to be very cautious when you use the emergency treatment. You can use it, but not in all the cases, and because and depends on the secondary cause. If the secondary cause is an uveitis, you can use the emergency treatment, but avoiding the charlatan, that is latanoprost, that is an prostaglandin analog, and this can produce more inflammation and higher pressure. So in cases of secondary glaucoma, we need to modify this emergency secondary glaucoma due to an uveitis. We need to modify this emergency treatment and make it different to try to avoid any complication. And in cases, for example, of a anterior lens luxation, it's probably not going to work. Because it's the lens itself that is sitting there, and is probably the pressure is not going to go down and back to normal with the emergency treatment. So in these cases, we need to try to program we can try it, but we need to program the surgery as soon as possible. So in some cases we can use it, and some cases we need to modify it, or sometimes it doesn't work.
Sounds like a good one to get advice from somebody who's got a lot of experience to me. You mentioned that with cataract surgery, there's a high sort of success rate. What sort of success rates do you quote to clients when you're talking about doing a phaco?
In dogs, now we are talking around 90% of success rate. We have a quite high success rate. Depends on the paper you look at. It's within 85 and 93, 95. But the success rate is quite high. And if we don't do the cataract surgery, we have complications as well, like anterior uveitis and lens luxation. So the recommendation is always to perform a cataract surgery if possible, because we have a high chance of recover of the vision, and we reduce the complications of leaving the cataract there.
Okay, cool. And in terms of the anterior lens luxation, you sort of mentioned this transcorneal reduction. Are there particular cases where that's not something that you would recommend doing?
This tends not to work in young patients. So this is something to consider in very old patients that we don't want to anesthetize, and we can do a light sedation. But I wouldn't try it. I wouldn't recommend you to try it in younger patients, because the vitreous body is quite jelly. Is when you get older, the vitreous degenerates and is more liquid. And if you push the lens to the back and it's liquid, the lens will stay in the back. If you push the lens to the back and the vitreous is a gel, it's going to stay in the middle and it's going to come back to the front. So you will not be able to push it to the back, because there will be something that is pushing the lens to the front again. So if the animal is less than, I could say, 8 years, is something that is difficult to perform.
Mm-hmm. Okay, brilliant. A couple more questions. You talked about the cancer-associated retinopathy. Is that usually a unilateral or a bilateral condition?
Usually it's bilateral. all these cases of in these cases we think that there is something. Well, in the Cushing we know that the cortisol arrives to the eye and kills the cells. So there is something coming from the tumor that suddenly kills the cells. So usually it's bilateral and very acute.
And presumably a bit like the other causes of retinal blindness, mostly permanent. So you're not going to, if you treat it with chemotherapy, you're not going to see the vision coming back.
No, no. These cases, well, the only thing you need to do is to try to find the cause and treat the cause, because if you leave the cancer there or the Cushing or wherever, the dog will have other problems. But for the eyes, there is nothing to do.
And I think you mentioned a couple of sort of genetic conditions like the PRA and anterior or primary lens luxation. Do you recommend genetic testing for dogs that are at risk of those conditions?
For the PRA, there are quite a lot of genetic tests that some breeders perform. And for the primary lens luxation, there are genetics tests as well. The problem with the genetic test is that if it's positive and we have the condition, we know that this is a hereditary condition. If it's negative, there are other genes that we don't know that are involved in these problems. And so we cannot say this animal doesn't have the problem if the test is negative. So some breeders sell the dog to the owner saying it's negative to this test. The dog will not have a primary lens luxation or will not have a progressive retinal atrophy, and we know that this is not true. So because there are other genes, other multifactorial genes or things that can produce these problems, and we cannot test for all of them.
Brilliant. Thank you very much for your excellent talk and answering the questions we've got tonight. And thank you to those of you who've joined us live and those who will join on replay for attending the webinar today. If you want to know more about the webinars we've got coming up, there is a QR code on the slide that's there, so you can scan that and find out about what else you can listen into from VET.CT. And if you want to know more about the Specialist Advice Service, you can drop me an email and we can set up a discovery call to tell you a little bit more about that. So thank you all for your time this evening, and we'll say good night. Thank you very much. Bye-bye.
Thank you. Good night.